So, coming to our next case by Syed Ali Shiram, percutaneous intervention of a leaking vein graft pseudoaneurysm.
Bismillah ar-Rahman ar-Rahim. Good evening, everybody, and thank you, sir. It's my honor to present in front of this august gathering this unique case of percutaneous intervention of a leaking vein graft pseudoaneurysm. So this is a story of a 63-year-old man with a history of triple vessel disease having undergone bypass graft in 2019. He presented now to us with the complaints of recurrent episodes of heavy bleeding from a wound at the lower one-third of the sternum, for which he was managed initially with blood products. When he presented to us, his clinical examination was unremarkable except for that draining sinus at lower one-third of the sternotomy wound. His clinical and biochemical profile and the coagulation profile were also normal, except the hemoglobin was 12 grams per deciliter. So this you can see on the left side that there is a draining sinus at the lower one-third of the sternotomy wound. And on the right side, you can see the CT angio showing a pseudoaneurysm. This is a huge aneurysm that was connected to the draining sinus through a fistula. There you can see this fistula that is connected with the draining sinus that is draining outside. And the coronary angiogram confirmed this gigantic pseudoaneurysm at the distal end of the SVG to PDA. This measured about 19 into 20 millimeter. The case was discussed in the heart team meeting. It was decided to percutaneously close the pseudoaneurysm using covered stents, since the surgical closure involved increased mortality and increased bleeding risk. After taking the femoral access, 7 French multipurpose guide was used, and a run-through guide wire along with fine cross were used to cross the pseudoaneurysm. However, the wire took a loop inside the pseudoaneurysm, as you can see in this encircled box, and the fine cross also took a loop over the wire. And while we were maneuvering with the fine cross, the wire took another loop proximally. So, meanwhile, while we were dealing with this, everything was thrown out. So we had to renegotiate the pseudoaneurysm along with the guide wire and the fine cross. And this time we thought of taking a stiffer wire, that is the Grand Slam wire, with the fine cross in place. So after that, the dilemma was that there was a loop in the, inside the aneurysm, how to straighten that loop. So we took an anchoring balloon distally, and by inflating the anchoring balloon, we pushed the guide liner over the wire. And after a lot of effort, we were able, to successfully straighten the loop of the wire with the help of this maneuver. This did wonders for us, as you can see in this clip. Then the anchoring balloon and the guide liner were removed, and with the loop straightened inside the pseudoaneurysm, this is the picture, as you can see. So after that, we took a stent that was the covered stent, it was 3.5 into 20 millimeter, hoping that it would cover the area across the pseudoaneurysm. We positioned it and deployed the stent across the pseudoaneurysm. But the picture afterwards showed that there was leakage at the distal edge of the pseudoaneurysm. So we then post-dilated it with 4 into 10 millimeter non-compliant balloon. And the picture afterwards showed that the leakage was still persistent from the distal edge. So then we decided to take another covered stent, and this time of a bigger size, 4 into 16 millimeter, to cover the distal edge of the pseudoaneurysm, overlapping with the proximal stent. So the stent is being positioned in the distal part of the pseudoaneurysm, across the pseudoaneurysm, and this stent is deployed. After deployment, the mild leakage was still persistent, and we again post-dilated it with another 4 into 12 millimeter non-compliant balloon. So the final result after post-dilatation showed complete occlusion of the pseudoaneurysm, as you can see in this clip. So a few words about SVG pseudoaneurysm. It's a rare complication occurring in only 0.07%. Fistulas are even more rare, with bleeding or sudden cardiac death can also occur in case of SVG pseudoaneurysm. RC is the most common site, and the treatment options include medical, surgical, or the percutaneous, of which the covered stents have also been used, but there are only 2 case reports of using covered stents to close the pseudoaneurysm. None has been reported from Pakistan previously, so this is the first case from Pakistan. So the take-home message is that's a rare complication, but it can be life-threatening. So timely diagnosis is essential. And percutaneous management using the covered stent or other approaches is a viable option, and it can be life-saving. I thank you all for your patient listening.
So I want to ask, what kind of covered stents were those? Jomed or they were
The covered stents PK papyrus.
papyrus? Okay.
Because we thought they are more flexible and more, the crossing profile is smaller and easily flexible.
And what anticoagulation did you put the patient on now, since you have two, technically you have 2 layers, but it's not like Jomed where you'll have 4 layers, but still what kind of anticoagulation or antiplatelet therapy that you put patient on?
Before that, we were placing him on heparin while he was admitted, but after that, we placed him on double antiplatelet therapy.
Because long-term follow-up, once you're putting in 2 covered stents, would not be very good. Although you inflated these with 4O balloon, they are very notorious to get closed again. So they're not the best option, and that's why they are not indicated for elective use. Another comment is when you bring the guideliner in, you use the inch-warming technique. Just make sure the balloon is a little bit closer to the guideliner. This is a vein graft. It's unlikely to get dissected. But in the natives, it can cause dissection if you're just bringing guideliner like this bareback all the way down. So these are the 2 comments. I think the antiplatelet or anticoagulation, you may have to look up in the literature and see if there is any other. You may want to put a rivaroxaban or some other form of pixaban for these. Some, with 2 covered stents in there, and they're together,
Yes, we have done the case of saphenous vein graft pseudoaneurysm in Agha University Hospital in 2019, and we are able to publish that case in Society of Coronary Angiography and Intervention, and it was a really interesting case, and we was able to close the pseudoaneurysm with the coiling. And
so that was with a coil. I'm talking about the covered stents. With the covered stent, this was the first case. There have been numerous case reports of closing them with the coil and the vascular plugs, but they are generally used when the graft is not patent. So once the graft is patent, you have to keep the patency of the graft as well. So that keeping in mind, we use the covered stent, so graft office also remains patent, and the pseudoaneurysm is also closed. So that's, in that sense, it was the first case. Thank you very much for the comment.
As in after first as well as after the second stent, there was distal extravasation. How do you see the use of IVUS for proper sizing before putting in the covered stent?
We had no experience of using IVUS in such huge aneurysm, because even if the IVUS is used, it will show the area inside the pseudoaneurysm. Probably, even this would not be helpful in exactly measuring that. Since it was the first case of ours, so we never thought of it.
How about after putting in first and then before putting in the second stent, IVUS in between?
Yes, this could have been used, but still there was a gap inside, and in that time we already knew there is only small areas left, so we could easily cover it with this smaller sized stent that was available and overlapping the proximal stent. So we didn't thought of it. Yes.
Yes, Dr. Naeem.
They managed well. Another thought, did you take any opinion from the interventional radiologist regarding putting a balloon in the SVG to occlude the flow, and then putting glue subcutaneously to close the fistula?
It has a sinus tract, so IR can access it from outside. But the problem with the glue is it can get down into the SVG and cause coronary ischemia.
But again, if you
yes, that would be a very cheap glue.
Yes, that's a very valid point, but we do not have an IR in our institute, so that could have also been done. So we discussed in the heart team meeting, there was a radiologist, but there was no input from here regarding this side.
Coiling is another option.
Yeah, coiling again, we discussed because the neck was very wide.
Yes. So the coiling is, yes, it's a very good option, but generally reserved for the cases in which the aneurysm is small and the neck is, neck is small, it's against coiling because, if for the coiling you have to have some sort of small neck available, because if it is smaller neck, then it can cause occlusion of the graft as well. So as far as I studied in the literature, so the literature says that for the coiling you have to have some neck, because smaller neck and large aneurysm is against coiling. That doesn't favor coiling.
Sir, a great presentation. So my question is, how do you angiographically decide that this is a pseudoaneurysm or is it true aneurysm? Does it hold true like in LV? We have pseudo and true aneurysm. Is it true for these cases as well with SVG aneurysms?
Okay, a very good question. Thank you very much. Basically, it's the histopathology is the same. That is the aneurysm, it's a true aneurysm, it contains all the three layers including the adventitia, intima and media. But in pseudoaneurysm, one of the layer is missing. But on angiographically, the pseudoaneurysm are more common, 6 times more common as compared to the true aneurysm. And the pseudoaneurysm, they generally occur at the origin, at the anastomosis sites. Like in this case, it was at the insertion point of the SVG to PDA. Most commonly, it is because of the faulty stitches, that can rupture and then can lead to, when there is a tension on the that anastomosis site, that can lead to rupture and that can cause the pseudoaneurysm formation. And same can occur in the proximal site at the aorto-osteal location of the grafts. So these sites are more common for the pseudoaneurysm. But true aneurysm, they generally form at the body of the main graft. It's rare at the insertion sites. Yes, please. Yes, this is a very good question, and there are no clear-cut guidelines for the management of such cases. But we plan to keep him on DAPT for 1 year. Any other question? Okay, thank you very much.
So we shall be heading towards our second last case of the day. And I would like to invite Dr. Abdul Salam Majeed Agha to present his case, Successful Management of Diagnostic Catheter-Induced Left Main Dissection.
Thank you very much. Thank you very much for inviting me here and giving me the opportunity to stand on this stage and present my case. So, assalamu alaikum everybody. I am Dr. Abdul Salam, an interventional fellow from Tabba Heart Institute. And I'll be showing you a case in which we have successfully managed left main dissection. It was a diagnostic catheter induced. So I'll start with the name of Allah. Bismillah ar-Rahman ar-Rahim. So my case was of a 75-year-old gentleman. He was function class 2 pre-diabetic. Presented to the clinic with history of 2 episodes of prolonged chest pain a day earlier, resolved after ACS medication given in a nearby hospital. So we have admitted him for further management as ACS and his troponin were negative. So we decided to proceed with a coronary angiogram. So we brought the patient to the cath lab, and as per protocol, he was prepared. Right radial axis was taken 6 French, and 5 French Tiger catheter was taken, and multiple attempts to engage the left main. It was not an easy engagement. So ultimately, it was engaged, and the angiogram was taken. So these are the RAO-caudal and the LAO-caudal views. Okay, so I'll come back to these views. So after taking these 2 shots, the patient started complaining of chest pain, and a gross ST changes, rather ST depression, were noted on the monitor. So what happened over here? Why suddenly patient was completely fine and he was asymptomatic, vitally stable, ECG was fine. So I want to, can we run it again? Can we run these videos? Yeah. So I think you can appreciate that there is a flap in the left main. Maybe it was not in the first injection, it was not noted that way the second was taken. But there is a flap in the left main extending and there is a complete occlusion of the circumflex artery. There is some disease maybe in the mid-LAD which doesn't seem to be obstructive. So we are dealing with left main dissection which has caused a complete occlusion of the left circumflex axis. So we switched to the femoral axis. A 7 French was taken. JL 3.5. Please just look at this. 3.5. 7 French guide was taken. And first of all, we have put a wire in the LAD. We have secured the LAD. Then the ramus was also wired. And we attempted to wire the circumflex artery. And by the grace of Allah, luckily we have succeeded in wiring the true lumen. And the injection was taken again. So I think you can see that a big circumflex is ossifying now, which was previously occluded. So as we see, the circ flow has been restored, and immediately the patient starts feeling better, his pain has resolved, and STT changes has also resolved and settled. So that's the main thing. So the rest is going to be a PCI, the way we do it routinely. So left main to circ was ballooned with 2.5 regular balloon up to 12 ATM. Then subsequently 3.5 by 38 drug-eluting stent was deployed from the ostium of the left main extending to the circumflex, and it was deployed at 14 ATM. Initially, a port was done in the left main with 4.5 NC balloon up to 16 ATM. Then we have post-dilated the stent in the circumflex with 3.5 NC up to 20 ATM. After doing this, we have rewired the LAD and the ramus. So we have the ramus is a good length vessel, but it's kind of like, a medium, what to say? Yeah, it was binged, and it was not, the diameter was not a big vessel, so around 1.52. So it was pupa with 2.5 regular balloon up to 10 ATM, and after that we have done a kissing balloon inflation with 3.5 balloon in the circ and 2.5 regular balloon in the ramus. This is not moving on now. Yeah, thank you. So we have utilized the facility of IVAS since we are dealing with left main and such a complicated case. So the IVAS was done, and we have found that actually, despite all this post-inflation, whatever NC balloons we have done, the stent was actually under-deployed. So the stent in the circumflex was further post-dilated with 4O balloon up to 20 ATM. Then we have done the kissing again with 4O balloon, this time in the circ, and 2.5 balloon in the ramus, and we came back to the left main, which was further post-dilated with 5O NC up to 18 ATM. So this is the result after doing all of this. The wire is still in the ramus over here. I don't know if you can appreciate that there is a dissection in the ramus, but still there was it was non-flow limiting. It was TIMI3 flow, not a big vessel I have mentioned earlier in terms of diameter. So we thought to leave it alone. So we have withdrawn the wires, and this is the final shot. You can see the wire is moving out in the last one. And in this view, can we run, please, the video? I think the dissection and the flap in the ramus is more visible over here. But again, TIMI3 flow, so still plan was the same to do nothing. Okay, if I have some time, I'll just touch that topic. So coronary artery dissection is one of, there are a lot of nightmares in the cath lab. This is one of them, and there is actually classification for that from class A, which is.
Thank you very much, Dr. Agha.
Sure.
We have crossed 5 minutes.
Sure, thank you.
Yeah.
Right.
So, chairpersons, any questions, any comments?
It's a tough case. I think it highlights the risk that we take anytime we do any diagnostic invasive testing. I think part of the reason was it's a really short left main and trifurcates, which was represented by the fact that you had to keep making your stent bigger. That was probably at least a 6O left main, maybe even bigger, right? So it's hard to get this stent to that size. why did you choose to stent left main to circ versus left main to LED? Did you think the dissection flap was extending into the circ? I know the flow was compromised there, but it was hard to visualize which way the flap is. What were the thoughts at that
Apparently,
point?
after we have inflated the regular balloon between the left main, the circ, the flap has disappeared. So that's why we have decided that once we put the stent over here, the LED is safe. And I think we have seen that actually clearly after that. We had a wire over there. In case we are really stuck, we can put the second stent, which definitely we have tried our level best to avoid, and that's what happened, luckily. Alhamdulillah. Yes, sir, you are right. Actually, that can be considered as well. But actually, regular balloon has shown that, closing that area has saved the LED. So that was the reason.
Good.
Yes, Dr.
Questions?
Naeem?
Why, maybe I missed some points in your history. Why did you go for angiography on this patient?
Thank you very much for the...
Okay.
Unstable angina.
Unstable angina because
yeah.
drop was negative.
Yes, and thank you very much for this question, because I have asked myself the same question. Did it really worth it?
Yeah,
Yeah, so
especially
if I come back, if I have some time to show
Yes,
the take-home message,
especially when
there are a
you-
lot of things about the dissection and how to avoid it and all. But I think what I have learned, and everyone is supposed to learn, that please, your procedure should be 100% justified.
Yeah, exactly.
Actually, while giving a name for this presentation, I thought about calling it a simple angiogram turned into disaster. And that's what happened, actually. And luckily, we have expertise and skillful people who could have opened the circumflex. Maybe if I was alone, I wouldn't have been able to do all this. So we need to think 1 million times. It's a simple angiogram, but see what has happened over here. So just imagine yourself, you are doing this angiogram for a stable ischemic heart disease. You don't really know if he has actually an obstructive disease or not. And you end up dissecting his left main and putting like, 2, 3 stents and all, and keeping him on dual antiplatelets, along with the other complication and LV dysfunction and a lot of things. So angiography, yes, I have seen myself and my colleagues telling the patient and his family, we do it routinely, we do multiple procedure every day, it's 1 or 2 percent complication, but when the complication happens, it's 100% disaster. So please be careful, and I think this is, the message which we are supposed to take home. Not home, we're supposed to take it, to the cath lab with us and to the hospital. Thank you very much.
Why 7 French?
So 7 French, because we are dealing with left main and we don't know actually if we are going to bifurcate, we need multiple instruments and all. So I think that was actually wisely chosen.
Why not radial again, same route?
Yeah,
Why
actually,
not, why
yes.
switch to femoral?
So yeah, quick discussion.
I mean, if you go, difficult engagement is one. If you are using the same route, the likely chances that you're going to sit in the same place. And taking a femoral route will change that orientation. GL4 would nicely fit into the ostium, which you do not want. Actually, you do not want a catheter which nicely fits into the ostium. Because that's where the disaster is. You want to sit outside the ostium and then start wiring it. And never use a hydrophilic wire when you are dealing with dissection. Use a regular wire, BMW, Scion, that's fine, but never use a hydrophilic wire.
Two comments. One is that, I think with this, the second view should not be taken.
Yes.
If you see that the left main is dissected, if you keep on taking views, you will keep on extending the dissection flap distally. So it was not realized. Maybe it was not realized. The other thing is take an exchange wire and take a guide right away. And the other thing, the last thing that I noticed was the ramus. I think I won't worry that much about ramus and the LED because we have to wire the LED.
No, the LED, all three were wired.
But yes, so the ramus may not need to be dilated even. Because if you no, but you are distorting a stent at a carina, at an area where it is dry.
So in early part of your career, if you come across something like this, as our esteemed colleague said, just don't inject anymore, just call for help. This hydraulic propulsion of dissection is where the case gets worse. And all of us during our careers would lose a patient or see something, because you get panicky, you keep on taking pictures because you're not sure. And the other thing is, I think femoral access was a reasonable choice, and just keep the guide outside the left main os. It should be just sitting in the cusp, and do some non-selective injection to get some idea, and then start wiring using a non-hydrophilic wire. That's the take-home message from this case.
Yes, please.
What if you wire the circumflex distally and you're not sure you're in the true lumen or you're in the false lumen?
Did you think of, did you think of imaging initially, rather than you did IVUS in the end for stent post dilatation? What about use of IVUS early on?
Before that?
Yeah, exactly, to confirm where is your wire.
Actually, that was the plan. But as soon as we wired into the circumflex,
all three wires there, injections over there, there was no IVUS.
Yeah, initially it was the plan, but if we were not very clear whether we were in the false lumen or the true lumen, the plan was to use the IVUS initially. But as soon as we entered into the true lumen, the chest pain, the ECG changes, the dye hanging out, everything disappeared. So that was very...
The wire keeps the flaps away as well.
It doesn't matter. I mean,
yes,
if it disappears, it means that we are in the true lumen.
Yeah, we did this in other cases of dissection, actually, to identify the true lumen. We have taken IVUS, and it was IVUS guided basically through true lumen wiring. So, yeah, but luckily...
I think dealing with a left dominant system and a left main dissection, did any point in your case you thought about putting patient on a hemodynamic support?
In the beginning, actually, we didn't even know actually what is the dominancy over here. Actually, rather, if I go back to the case, can anyone tell me actually what was the culprit? Patient came with ACS. So ACS came from where? From which vessel? Is it the left main, circumflex, LAD?
No, but...
no, I'm sorry, just coming back. I'm coming back to your question. So, like, once we have dissected, we don't even know actually what has happened and why the patient is here right now. The only thing we know that we have dissected the left main and we have created a big mess over there. And regarding this, as I told you, actually, the RCA is not seen, circumflex is not visible because actually it was occluded, so we don't know what is the dominancy over there. Patient was still hemodynamically stable at that time, apart from the chest pain, so I don't think there was an indication for the balloon pump at this point of time. And as I mentioned, luckily and by the grace of Allah, it was wired, on time. So
thank you very much, Dr. Agha.
Thank
When
you.
end is well, all is well, right? Right. So we had very nice cases, very intelligent discussion. Now we are coming to our last case for today. And for the last case, Dr. Adeela Shahzadi would be presenting the case on behalf of Dr. Irfan Rizvi, as he is not around.
Assalamu alaikum. I'm Dr. Adeela Shahzadi, resident FCS Cardiology, Cardiac Medical College, Bahawalpur. So I will be discussing with you a case of PCI to LAD, which was complicated with septal perforation, and we handled it using fat embolization. So this is the story of a 61 years old female who is a diabetic and hypertensive, and known case of ischemic heart disease, as she has anti-AVAL MI 1 month back and presented to us with post-anti-AVAL MI angina of functional class 3. So her ejection fraction was 40%. We planned her coronary angiography, which showed that there was almost 90 to 95% occlusion of left anterior descending artery, while the rest of the both arteries were non-obstructive. So we planned her PCI to LAD. As you can see, that there's almost 90 to 95% occlusion of LAD with TIMI 1 to 2 flow. So we started the procedure. As usual, we took an XB3 6-French guide catheter. Our first choice was our workhorse wires BMW wire, but it unfortunately couldn't cross the lesion, so we exchanged it with a pilot 50 wire, which successfully crossed the lesion. We pre-dilated the site of stenosis and parked 2 stents. We justly parked a stent of 2.75 into 12 and a proximal stent of 3.038. and we post-dilated the lesion. So far, things were under control, everything was fine. But when after post-dilatation, the check injection was given, it revealed the catastrophe, and there was a distal LED septal perforation. This is the stunt that was parked. And here is the post-dilatation check injection. And you can see that there is septal perforation at the tip of the guide wire. So what we did what we're supposed to do, call for help. There was emergency declared in the cath lab. Inflated balloon inflation was done. Meanwhile, we did her on-table transthoracic echocardiography, which revealed that she was having only mild pericardial effusion. We kept on doing the serial echoes as well on the table. And luckily, she was relatively hemodynamically stable so far. We did balloon tamponade for 3 times for 5 minutes each, 5 to 10 minutes almost. And meanwhile we changed our pilot wire with another BMW wire and placed it in the at the site of the perforation and harvested the fat embolus from upper thigh and mounted it on the microcatheter. Here you can see where we did the balloon tamponade. That was, like most of the times of perforation was not of no use. But we took a microcatheter to the site of perforation, which was having a mounted fat embolus on it. Here we have placed the fat embolus. So these were the steps. We took fat from the groin, mixed it with the dye, placed it on the microcatheter, and with the help of an introducer, and then injected the dye further end, which is embolized at the site of perforation. But unfortunately, the first embolization was unsuccessful. So we have to repeat the procedure of harvesting the fat, and again we attempted this embolization. You can see that first embolization that was not successful, and there is still leakage from the perforation site. Here we took another chunk of fat and we have taken it to the site of perforation and parked it successfully here. As you can see that there is no more leakage from that side, and the perforation was successfully sealed. As you can observe, the flow is relatively slow. So we gave intracranial nitroglycerines and adenosine, which relatively improved the lesion flow. Sorry. What we did was shifted her to the emergency department. We keep on monitoring her via echocardiography. We must remember that in late distal perforations, there are chances of late development of pericardial effusion. So we did her serial echoes every 4 hourly, and then after every 24 hours. And when there was no increase in the size of pericardial effusion, and she remained hemodynamically stable, and she was discharged on the 3rd day of the procedure. And even after the 2 weeks of follow-up on the clinics after this procedure, she was doing fine. So fat, that is not really good for a cardiologist, but for interventional cardiologists, it can save the day. And it's a good thing if it saves the day finally. Thank you very much.
Thank you very much, Dr. Adeela. So it's always important to take care of distal wire tips while doing a procedure. Yes, Dr. Osman.
Few comments on the...
Okay. Yes, please. Go ahead.
So one is that this septal perforation would cause septal enema.
Yes, sir.
So you won't see anything on the echocardiogram. That's one thing to understand. So the patient may develop, sudden arrest
blocks
because of the expanding metabolic. The other thing was this choice of a CTO wire for apparently an acutely occluded LAD may have been the reason. Because you don't use a pilot 50 wire for an acute occlusion of the LAD. So these are two comments.
Yes, Dr. Tayyab.
I think the main take-home message is just keep an eye on your distal tip of the wire. That's the most important, so you never have to use this fat trick. You can use patients' own blood also, but these patients are totally anticoagulated since you're doing an intervention. But if by chance there's a blood sitting, clotted blood sitting, patient's own blood, that could be very easily used, and it's much easier to inject through a microcatheter or an OTW as compared to fat. And I don't know how they use. Usually you take an 18 gauge needle and then you cut the groin, and through that those small bubble things that come out. Yeah, that's how you do it. And it's not easy to push it in through the support catheter. And we don't have microcatheters in a lot of cath labs, so you can use OTW. And as my colleague said, you very rarely die from a septal perforation. Patients actually get a lot of chest pain from it, and they can get VT from it also. But usually it's not a big issue. If you cannot do it, just
tamponade effect that
it's very rare to get a tamponade effect from that. So even if you cannot, the patient just needs to be monitored. I'm more worried about the LED stent than the septal perforation there.
Yes, Dr. Shahadat, would you like to say any words?
Any complication in cath is depend on the patient, how much patient is giving the time to you. If patient is giving time to you, you are lucky enough to manage.
Yes, so we were lucky enough that she gave it time. She remained stable
throughout.
If
didn't give you time, you can't do anything.
Yes, sir. We were lucky that she gave us time. She remained stable.
Yes, Naeem.
My comment on this, definitely when you are using polymer jacketed wire, so you have to look after your wire, because you don't know about the anatomy, especially disoccluded vessel, so it can perforate. You have to be careful. Regarding the management, as my senior colleagues mentioned, that septal hematoma, definitely patient can go in arrest because of VT. In such cases, definitely there won't be any visible pericardial effusion. Regarding the management, they have done very good job. Definitely it's very cumbersome, as they mentioned, to put the fat pieces and bubbles in the macrocatheter. The other parts of the management in these cases, if you have coils with you in your lab,
but
that can
we didn't have them on our shelf, so we have
and
to.
the simplest, other than coil, the simplest way is you can just cut pieces of the balloons. You can, if you take a balloon long enough, if it's a septal vessel, you can take a 2O balloon. If it's long enough, like 15
The option could have been a covered stent as well?
No, covered stent won't be. And having a small covered stent will be definitely, it won't be available in everything. So a cut piece of balloon is a good option. You can use 1, 2, or 3 pieces in such cases, and you can seal it effectively.
That can work.
Yes, if you have a OTW balloon, so you can cut the first half of it.
Then it
feed it on the wire, and then you take it on the wire. Yes, and leave the distal half there.
Exactly.
Just there, and just leave it there, the distal half of the OTW.
Rather than using 2 balloons, you can use 1 balloon.
One balloon. Okay. Yes, Dr. Ahmed. Okay. Yes, Dr. Kaleem, please.
Yes,
and what my other colleague has suggested, especially for fellows, you have to do a distal tip while managing. Normally or proximally, we treat the vessels and forget about the distal vessel tip, and it sometimes go away and by manipulation. So important message is that always keep an eye on that one. Yes, I was a fellow when I was doing a procedure along with my, we have done a fate embolization trial to the wire perforation. Yes, it is very difficult to get a fate from it, especially to get the fate and put it in the OTW balloon and get it there. We can use the coils, there are certain coils available.
Sir, as I told you that it was not on our shelf, and sorry to interrupt, but we had this is the second time we have done this procedure. Fortunately that in both the cases we were lucky that our patient did well with the fat embolization. So we took a chance on it, repeating the cumbersome procedure.
Bahawalpur has got a lot of it. Huh?
Yes, sir. Yes, sir. Likely it wouldn't going to benefit at all with this much anticoagulation.
So did the pericardial effusion ever go beyond mild, or did it ever accumulate, or not really?
Anji, sir? Yes,
Did
sir?
the pericardial effusion ever increase, or was there any significant change in the pericardial effusion? It sounds like you did a lot of echoes, but there was never really
No, there was
pericardial
not.
fluid, because your location on angiography is clearly septal.
Exactly, sir.
But
yet
from a
we
septal
have to do
perforation, I'm trying to figure it out anatomically how you would get a pericardial effusion, and so far I can't figure it out. So it may be that where you're seeing some of that free flowing is contrast, maybe the distal RV or muscle, and that's why you're thinking it's pericardial. So the concern is that you've done long balloon inflations in the distal LED after fresh stents in an ACS setting. You clearly had TIMI2 flow at the end of the case, and so a septal perforation may not need all of this stuff that was done.
But sir, balloon inflations were we did it 3 times, but they were unsuccessful. One thing, and the other thing is the flow was not that good after at the end of the procedure. This is what we learned, that first thing that we should have exchanged the wire as soon as we have crossed the lesion, and second thing is that the amount of fat should be
if you back up a little bit, what I'm saying is that if it was just clearly a septal perforation, then you didn't need to do all that and jeopardize some of the procedure and the good work that you've done with the stents upstream, because fresh stents, TIMI2 flow, ACS situation, long balloon inflations, so you could have thrombosed your stents or had further problems downstream. The fat also is hard to control when you're so distal and just the tip of the catheter is in the septal vessel. And if maybe some fat embolized down the apical LED, and that's why you had reduced flow. So for me, the take-home point would be that be very clear where the perforation is and what the risks are, because if it was just a septal perforation, then it could be left alone.
Yes, sir. Thank you very much.
Okay, thank you very much, Dr. Adeela. Thank you very much, all the audience, and thanks to all the chairpersons. It a very nice session, and I wish good luck to all the presenters, right? And the best one would get the reward. Thank you very much.
So once we are done with the 3 more fellows course corners tomorrow, we'll be announcing the best 4 cases in the closing ceremony at the end of the conference tomorrow.